Hi, good evening. Welcome to Milford Regional Medical Center. I'm Donna Boynton from the marketing department. Tonight we have with us Dr. Michael Sganga. He is a podiatrist with Orthotics New England located in Hopkinton. Dr. Sganga is a graduate of Temple University School of Podiatric Medicine, and he completed an internship and residency in podiatric medicine and surgery at Mount Auburn Hospital in Boston, and he also completed a fellowship in surgery at Harvard Medical School. Tonight's program is being videotaped, and it will be posted on our website in about a week or two for you to review and share for those who might not have been able to join us this evening. So, Dr. Sganga.
All right. How's it going, everybody? I'm going to turn this on. Got a little lecture just kind of going over foot and ankle pain and some symptoms, some common problems, some common fixes, and this is your time. I mean, I'm here for you. This isn't about me talking about me or anything that I do. It's you kind of getting a forum to learn a little bit more, ask some questions. Feel free, shoot up a hand, raise a hand, make some questions throughout. I'm here for you. This is your time. I'm a New Yorker who's transplanted here in Boston. I met this young lady in Ithaca, New York, where I went to undergrad, and after she followed me to Temple for medical school, she made me promise that I would come back to her homeland. And as a New Yorker, I gotta say I do really love Boston. I'm also an athlete. I play hockey, I cycle. I'm very active in my lifestyle. I've had surgery myself. I've had hip surgery. I know exactly what it's like to have an injury, rehab from surgery, and recover. And I think it really helps me put myself in the chair when I'm talking to a patient about surgery. I tend to be very honest upfront and sort of blunt about foot swelling, stiffness, pain, what to expect, and that it's not just a 6 or 8 week recovery. It'll take you a couple months before you're really moving and back to yourself again. Because I've been there, and I want to basically tell you what I'd want to hear if I was sitting in the chair being told this is what needs to be done, but this is the recovery. So your feet and ankles, they're your workhorses. They do everything for you. They're your foundation. They hold a lot of weight. Some did you knows? 1 minute of walking can add 2 minutes to your life. It's never too late or too early to start exercising and get out there and move. Studies show that older people who've led active lifestyles have less health problems as they age. And according to the U.S. Health and Human Services, physical inactivity can contribute to about 300,000 preventable deaths a year. Some benefits are cardiovascular health, mental health, just overall health, disease prevention, and management of diseases such as diabetes. Generalized foot pain, heel pain, ball of the foot pain, Achilles tendonitis, stress fractures, broken bones, these are some of the things I see on a regular basis and treat. And any of my patients who are going to be active, I recommend if you're going to start an exercise plan, start your workouts gradually and make sure you consult with your physician before any exercise plan and make sure you're healthy enough, or at least start slowly with a bike before you start going out and running. Wear the right shoes. They make walking shoes, running shoes, hiking shoes for a reason. They're all different types of shoes and designed to perform differently. Use good technique. Listen to your body. If it hurts, don't push through it and think you're gaining more. You're actually losing more because it's going to take you longer to recover. The foot's complicated. The foot has 26 bones, 33 joints, and over 100 ligaments. That's almost more than any anatomic location on the body, and that's one of the reasons that I chose it as my specialty. Impact factor. With walking, heel impact is about 1.5 times your body weight. Running and jogging can go up to 3 to 4 times that force. Impact sports like basketball or tennis, that can be 8 times your body weight. So one of the things that I counsel patients on is if you're having foot pain, even losing 5, 6, 7 pounds times 8 when you're running and playing basketball, that's a lot of weight off that foot and oftentimes has a huge impact on your symptoms. Common conditions and things that I treat: plantar fasciitis, Achilles tendonitis, flat feet, Bunions, Hammertoes, Arthritis, and hallux limitus, that's big toe joint arthritis, among all the other traumas and fractures and things. One of the things that I think I have a different sort of treatment idea towards is plantar fasciitis that I see a lot of. It's heel pain usually exacerbated after rest, getting some waves from the audience. I have had plantar fasciitis myself. It's really common. almost every American is going to suffer from it at some point. But it's typically due to tightness in your Achilles, repetitive stress, thinning of the fat pad, increased weight, worse first thing in the morning, gets a little bit better, but then worse at the end of the day again. And a common complaint is worse with driving and getting in and out of the car. Treatments range from shoe inserts, padding, offloading, arch support, stretching, run the gamut. There's all sorts of night splints and boots and resting and things like that. And I have sort of transitioned into a conservative model first always, and oftentimes an injection is really helpful to speed things along. But there's some minimally invasive things that I do that are a little bit different than probably most of the other people around here as a procedure to treat this. One of the things I do is called a Topaz PR procedure. This procedure is minimally invasive. Topaz is a proprietary name, but it's minimally invasive. I have about 85% success rate in my patient population, meaning no pain at 2 months, and I've had very little recurrence of the pain. I also use it on Achilles tendons and chronic tendonitis, but the big thing about this is it's very minimally invasive. That's the grid we'll create on your heel, and it's basically poke holes. We do it in the operating room because it's a fancy, expensive machine that I don't have in my office, and it works fairly well. The whole idea is it's radio frequency. It breaks down the molecular bonds in the scar tissue at a low temperature, and it allows me to directly target your fascia and basically create an acute inflammatory response from your body. I also typically will harvest some of your blood. The anesthesia will draw it, we'll spin it down, and we'll take just the growth factors and inject it in there to supplement. And it works quite well. That's something a little different that I think I have to offer. Achilles tendonitis, something else that can also be treated minimally invasive in most cases, is inflammation at the Achilles tendon in the back of the ankle, and usually very painful and limiting, especially for runners. Ankle sprains, I see a lot of ankle sprains in every age group, and the basics of it are modify your activities, rest. Symptoms can be instability or a wobbly feeling in the ankle, giving out, giving way. And really the severity depends on how many ligaments are damaged and if there's bruising to the bones associated with it. I think the worst thing that I hear is people say, oh, it was just a sprain. And now we're 3-4 years later and it still hurts. I think if you have a sprain, and my mantra is it's never just a sprain. If it's lasting more than 5 to 10 days, you haven't gotten better with rest, ice elevation, get in and get it looked at. If you have symptoms of catching or wobbliness or giving out, get someone to take a look at it. Get an x-ray, get a clinical exam, and make sure you don't have a little chip to the cartilage or ligaments that are torn beyond what they should be. You might even just need a boot for a few weeks, a brace, and some functional physical therapy. The ligaments around the ankle don't just hold the ankle together. They have nerves within them that do something called proprioception. And that's that concept of when you're walking on an uneven surface, you don't have to look down. If you step off a curb, you don't have to watch what you're doing. It'll tell your brain where your foot is in space. When you tear those ligaments, you lose that capacity. That's why after a sprain, it almost feels like your foot's detached and wobbly for a long time. Proper rehab and proper physical therapy are the best ways to combat that. And also there can be injuries such as OLT. It's called an osteochondral lesion of the talus, and that's an injury to the cartilage in the ankle. And these usually do better when treated right up front. It can lead to bad arthritis later. Lateral ankle instability is kind of what I've been talking about, and if you look at this ankle, you can see these ligaments here are not holding the joint together, it's opening up. And that's from recurrent sprains or sprains bad enough that the ligaments were torn beyond the capacity of your own body to repair it. Fixing these ligaments is not as bad as it used to be. My protocol is a really quick rehab in comparison. It used to be 6 weeks in a cast, 6 to 8 weeks in a boot, and about 6 months before you can run. Now when I do this, you're really off the foot for about 2 weeks, and then I have you in a brace somewhere between 5 to 8 weeks. I have had athletes running at 6 weeks. I've had athletes running at 8 weeks. It really depends, but I try to be minimally invasive, as quick as possible rehab, and I really try to let you walk on anything that you can. Non-weight bearing is not something that I enjoy, and I don't think many other people do either, so I try to avoid it at all costs. Some things you can avoid non-weight bearing, but this is one of the things where I've been able to really push it. And another thing, just know your foot. Get to know what's going on with your foot. Do you have bunions like on this scale, or arthritis like here where you can see the joint and then see the large arthritic obliterated joint where there's no joint space left next to it? The one in the little picture looks normal. The one in the big picture is arthritis. So we'll elaborate a little bit more on that. Bunions are not just a bump. They're actual structural problems by which the ligaments stretch out and the toe deviates. You can get anything from a small bunion to a severe bunion where it crosses over and dislocates your second toe. Now, there's no indication to treat a bunion unless you have pain. And size of the bunion doesn't really correlate to pain. I've seen bunions smaller than that one all the way over on the side that hurt like you wouldn't believe, and one's so bad that the big toe touched the fifth toe and no pain whatsoever. So there's no reason to fix a bunion that does not hurt. Surgery is not cosmetic for this, but they are very fixable. And sometimes the symptoms are just pain on the bump, but shaving that off, it's going to come back, it's going to get worse. We have to correct it. So what do we do to correct it? We change shoe wear, we try injections, we try conservative management, orthotics, arch supports, wider shoes to accommodate the bump. These are all things that we do, and basically if it's getting better and you just wear a wider shoe, I'm happy. I'm a surgeon, I love operating, but you come first, and it's your foot. I will tell you this, and I tell multiple patients every day, it's your foot, your ankle, you tell me what you want to do with it. I'll review what's available, and you tell me when you're ready for surgery. This is elective, but can be very limiting. So I'm going to show you some x-rays and things after we talk a little bit about hammer toes. Hammer toes are contractures, and those knuckles get really arthritic and start rubbing on shoes. And it can happen when you're trying to balance. There's a number of different ways that hammer toes form. They can be extremely painful, or they can just be annoying and rubbing on shoes. And typically, what I see the most are little calluses or corns, which is thick skin that develop when they start to rub, or pain at the tip of the toe because that's the part that hits the ground, and when you straighten it out, it goes away. But treatment can be sort of similar, just padding and offloading and strapping, meaning getting the toes straight, little toe crest pads and things like that. And if the symptoms aren't relieved by attempted options with conservative care, you can see I go conservative until we kind of fail that, and then we'll talk about surgery. Fixing it works pretty well. Here's a couple of before and afters. These are de-identified patients of mine. This is a bilateral case, both bunions fixed, nice and straight, and you can see we use screws. We do things a little bit differently than probably done in the past, and I have some quick methods. This person was in shoes in, I think, 5 weeks on both sides each time. Now a year out from the left and I think 6 months out from the right, and doing great. More severe bunions and more complicated cases and revisions. This one here was a revision on the far right, your left. And they need to be fixed sometimes by more means. You can see there's more hardware in there, more screws, more plates. But I think the approach is, as long as you correct the bunion and you get that toe straight, you're going to have a great outcome. And in a lot of cases, we can save a joint from becoming terribly arthritic, and we can get people back to activity. Here's another one that involved a hammer toe with a little implant in there, and you can see we got everything nice and straight and lined up. So arthritis, you can get arthritic areas in the foot and ankle. There's many joints that can become arthritic, and some of them are easily treatable, some of them are a little bit more complicated. But pain and stiffness, swelling, limitations on motion, activity, these are all things that come about, and treatments typically are anti-inflammatories, injection therapy, orthotics, which is a big part of what I do also, which is an insert in your shoe that supports the arch and balances your foot, and I use them to treat a variety of pathology. But other options would be surgical, and there's ankle replacements, there's fusions, there's joint replacements, joint fusions of the big toe, and there's a lot of different options. It's really patient specific, and every patient gets basically a blank slate when they walk in my office, and whatever's going on with you is different than whatever's going on with the next person. You may have the same diagnosis, but the treatment may be completely different because it's individual. So hallux limitus or rigidus is a fancy word for arthritis of the big toe joint. And you can see here on these pictures, I don't actually know where the laser is on this thing, but there we go. The joint's pretty open here on the side, and you can see it's filled with arthritic change and spurring here. And we range from normal range of motion where the big toe is able to be brought up to a normal position and allows you to walk, to hallux limitus, where it's somewhat limited, painful, usually a lot of bone spurs on the top of the joint and it stops the motion, versus rigidus, where it's very arthritic like this case and doesn't really move. So options are pretty wide, and again, it's driven by your pain and symptoms. I tend to try to save the joint as much as I can and keep motion. The gold standard for any big toe joint arthritis is to fuse it, because it's a one and done stable surgery. And the way we do it now is pretty quick. I let you walk almost right away, and you're usually in a sneaker by 8 weeks. It's much quicker than it used to be. But options are orthotics, injections, padding, shoe changes, things like that. Here's a couple of examples of some fusions. This is arthritis not managed by conservative care. You can see this is a big toe joint fusion here and here. And the way I use plates and screws and realign everything, you can walk, you can run. This guy went back to soccer. This patient went actually back to wearing a 2 or 3 inch low heel without a problem. And everybody who I've fused has had a really good outcome. It's just a bit of a concept to wrap your head around, that it'll move down here, but this joint won't move on the toe. If the joint is so bad that I think you need a fusion, anything short of that's going to fail. There's joint cleanups, they call them a cheilectomy, or debriding the spurs in the joint, and then a variety of implants. And I do several different types of implants, which I'll show you in a second, but this was a midfoot fusion for arthritis through the midfoot to stabilize these smaller joints. So this is an example of a joint implant, and this is one of the newer implants that I've been doing lately. You can see the joint here is pretty arthritic. The toe is deviated, it's compressed, there's not a lot of joint space open, and here you can see the implant is this little square, and yep, there's my arrow. And you can see that the joint's a little decompressed, it's moving better clinically, and these have a much quicker recovery, usually only about 3 weeks in a boot, and then back to sneakers. Flat foot is something that can be congenital or acquired over time, and that's sort of a long-winded way of saying that one of the tendons in your foot is collapsing, your arch is collapsing, and it can be due to ligaments, tendons, or bone. And you can be born that way, meaning it's congenital, or you can develop it, meaning it's acquired over time if you get tendonitis. And as we get older, our ligaments stretch out, our feet do flatten naturally. You'll notice that you probably have a larger shoe size than when you were 18. Most people do, and especially after pregnancy, that tends to happen as our ligaments stretch out. But it's a very treatable problem, and I always go conservative first, whether it's bracing with a sports brace and physical therapy, orthotics. There's a variety of things that we can do to balance it. I might even make custom braces for this. But if needed, we end up going on to surgery. And this is only when conservative care fails. And I do a fair amount of this type of surgery, and it can range from large-scale fusions in the hindfoot to get structural alignment. But if the ligaments in the tendon are viable, I'll try to reconstruct everything. And I think I have an example here of how we do that. So here's just a basic example. There are literally dozens of procedures that you can do for this. It's tailored individual to the patient and the pathology and exactly where the problems are. Usually you see this with an MRI, a CT scan, and an exam. But this is an example of something that I commonly do. You can see here the difference between the two. There was a wedge taken on the outside to open up the outside of the foot. And you can see the alignment of that joint in the midfoot. And that joint, you can see now, is much more aligned with the great toe and straight on rather than pointing out and collapsed. And an example of that in a patient here is a young kid who had a bad, painful flat foot and tendonitis. And in this patient, we went on to lengthen the lateral column here. And you can see the angle is now nice and straight. And we've put the talus, this bone where I'm pointing, right back in line with the foot. And another osteotomy here to just help with arch height and rebalance the patient. And these tend to work really well. We actually surgically build you an arch and repair the soft tissues with tendon transfers, ligament repairs, and things like that. Here's another case of a patient of mine that I did a flat foot reconstruction on. You can see the angles increasing and changing. So significant collapse and declination through the talus and flattening of the arch. You can see with some wedging and soft tissue work, we really built an arch quite well for the patient. And they went back to resume activities, walking, hiking, biking, and everything. Ankle arthroscopy is something that I'm pretty excited to bring to the Milford community. It's something that's a large part of my practice, and it's something that I do on a regular basis. And I think I can do a lot through an ankle arthroscopy, whether it's cleaning up scar tissue, cleaning up some arthritis, repairing cartilage. I can do a lot of things. And when you have any of those cartilage lesions, like I talked about the OLT or osteochondral lesion, and if anybody has that or knows about it, it's basically an injury to the cartilage by which either the cartilage is damaged or the bone underneath is damaged, and either fluid can get in from the outside, meaning you have fluid in your ankle joint, and it can get in and cause pressure, or it can cause cyst formation, and it can break down the joint. And these can be treated very successfully. I have some options for actual resurfacing and allografting and replacing the cartilage. And there's a number of procedures that have been working very well. And as you can see, my goal is minimally invasive. If I can do this through an arthroscopy, sometimes a little incision like this, we can get really good outcomes for what used to be a very long, difficult recovery. So why do these things hurt? This is a schematic of the ankle joint, this sort of picture. And think about it this way. Cartilage is like the shingles on a roof, and the joint fluid inside is like a rainstorm. So as it's hitting that roof, if there's a loose shingle or a crack in the roof, this is going to start to leak through and cause some leakage into the house. It's going to drip down. Imagine it's just a one-floor house, and it's dripping down onto the basement floor. The basement floor is the bone underneath. Cartilage doesn't have nerves in it, so it doesn't really hurt when that penetrates. When it gets down to the bone, as you see here in this picture, that's when it causes pressure. And as you're moving the ankle, that increased fluid causes pressure on the bone, and that's when you start feeling the pain. So oftentimes people will say, well, I didn't injure it, how did this happen? But you could have some arthritis or an injury 10 years ago, a simple sprain, which I hate that word, simple sprain. And you could have injured the cartilage. And over time, the fluid wave finally got to the bone and pushed, and that's when you started having pain. This is sort of a schematic of the cartilage in your ankle and the blood flow, and it's relatively thin in comparison to other joints like the knee and the hip, and it's a very small surface area, so there's a lot of pressure with walking and standing. And a simple arthroscopy, these are the portals, those are my two typical incisions. And if we need to open one of those a little larger, I will just lengthen very slightly one of these incisions, and we can get great access to the whole joint. And you can see here on this schematic drawing, there's a lot of anatomy, but know your anatomy. It's very simple. I was an anatomy TA in undergrad. I was an anatomy TA in medical school. I was a prosector dissecting cadavers for all of Temple University, the dental, physical therapy, medical, and podiatry schools. So anatomy is important. It's the only thing that doesn't really change. You can learn it and learn it and learn it, but you got to know it. And I emphasize that to my residents that I teach, but it's right there. If you know what you're doing, it makes surgery much more simple. So this is one of the products, and I'm not really endorsing any product specifically, just so you guys know, this is just something that I use, and there's a number of different allografts out there. Allografts meaning it's taken from another person. Autograft is taken from you, allograft is taken from another person. And we can use this to resurface the talus and the ankle. And what this is actually particulated cartilage. This is donated from juvenile patients. And the way it's stored and prepared, it's viable, and it can actually incorporate and has been shown to replace cartilage in the ankle fairly well. I can do this most of the time through just an arthroscopy, sometimes a small incision. And also, of course, I do all sorts of trauma. You name it. If it breaks in the foot and ankle, I can fix it. And just some examples of a calcaneal fracture and ankles and a midfoot fracture. Also pediatric trauma. I don't really have any age limits. I see patients from 0 to 110. If you make it to 111, I'll see you if you ask. But this was a case where a young kid had dislocated his big toe and it needed to be pinned to stay back in place. So even the simplest things treated properly have great outcomes, but emphasize getting in there and getting seen quickly. And just an info clip, we do custom orthotics. I do a lot of these in my practice. I wear them myself, and they can treat a lot of problems simply with just an insert in the shoe. And we used to do them with plaster casting. It takes a lot of time. It's a big mess, gets plaster everywhere. Now what we do is a computer gait analysis. So we have you stand and walk across a force plate system, and it makes just as good a device as the casting, if not better, because we can actually see the pressure points and the instability in your foot while you're walking. And I am at 1 Lumber Street in Hopkinton. I do have 3 offices, but I'm here every Monday and have some of our info, and happy to answer any questions. So toe fractures take a long time. Once those little toes get swollen, they turn into little sausages.
Yeah,
And
it's really still swollen.
the problem is it's down there, it's in a shoe, it's on the ground, it's the furthest from the heart. And once that toe gets swollen, it just takes months and months and months to go away. You can use like a small sleeve, a little bit of what's called Coban wrap, but you want to be careful because you can put a tourniquet on your toe. So that's, you want to be really careful with putting compression on there.
And they,
So I've actually casted people for plantar fasciitis and just put you non-weight bearing in a cast when it's gotten so bad and just rested the whole thing. You mean a night splint? Yeah, that kind of pulls you up and holds it up. I give out a bunch of night splints. It's a very fine line. It's about a 50-50. 50% of people swear by it. And this is a personal anecdote. This isn't studied literature. But 50% of people swear by it. 50% of people say, I can't sleep with this darn thing. It pushes on my toe. I don't like it. And to those people, I say, wear it for a bit in the evening. And before you go to bed, kick it off and see if it helps. And most of them say that that helps. Stretching is the #1 thing you can do for plantar fasciitis.
10 seconds, hold it.
Tightness in the Achilles tendon. If we could get rid of that, I'd go out of business.
That's better.
Seriously, yeah.
Better than the boot.
It's definitely better than the boot. And, 30 seconds at least a couple times a day. But when you're stretching, it's that typical runner stretch. But you want to do it with the back leg straight and then step in a bit and do it with the knee bent. There's a couple of muscles that make up your Achilles tendon, 2 big ones. One is the gastrocnemius, that's that little teardrop shaped one. Starts actually above your knee. So with your legs straight, you're stretching that. Your soleus is that broad muscle kind of on the sides, and that starts back here below the knee. So to stretch that, you need to bend that knee and really get into the stretch. Yeah, anything you can do. The stretching is probably the #1 thing you can do to make it better. Yeah, Morton's neuroma surgery is a very common surgery, and there's a lot of different ways to do it now. The way I do it is typically through an incision maybe about this big, and I go right from the top, and the whole procedure only takes about 20 minutes. Very clean, smooth dissection. Try to avoid any scar tissue over dissection. I either release the ligament that decompresses the nerve because it passes under a ligament, and that's usually when it gets irritated, or I resect the nerve and bury it into a muscle in the back. And I usually try to be as quick and clean about it because you can get some scar tissue from it. We used to go from the bottom, and that's only for recurrent cases, meaning if it comes back, because you get a lot of scar tissue on the bottom. But there's always options for scar tissue, whether it be injections or scar tissue releases and things like that. So if it's something that plagues you, there's stuff to help. So that's a loaded question because now every company has every single model just about of every shoe. I usually would recommend you go to a good running store. You don't want to just go to Dick's Sporting Goods and get the pink ones or the green ones. I would go to a place, and no affiliation whatsoever, but PR Running in Westboro or any of the Marathon Sports locations. They're excellent. They will actually take the time to measure your foot, which most of us haven't had done since we were 16 years old and a kid. And they'll watch you stand, watch you walk. If you tell them what's going on, and oftentimes I'll write even on a card what your diagnosis is and kind of what I'm looking for, they'll pick down to 2 or 3 shoes. Maybe they won't have them. They'll order them for you, and they'll get you the right shoe. Brands that I've found patients really seem to fall in love with are anything from Asics, Brooks, Saucony has good product. Hoka is a newer shoe. It's like a maximalist thick foam shoe. Patients with neuromas actually really love them. So there's a lot of variety, and it's basically its own specialty. I wish I knew more about shoes, but it's impossible. They change every few days. I'm a big proponent of pretty much anything that can get you better. Massage therapy is excellent, especially any active release techniques, things like that. And I kind of leave it up to the patient. I mean, we can run down a list of a ton of stuff, but are you in the area?
I am.
I'd like to get your card. Kind of everywhere I go, I try to meet as many folks as I can and develop connections, because I think a team approach and connecting specialties of any kind is a really good way to go about things. And if I can kind of get you a diagnosis, an idea, and kind of pass you along to someone, and we can get you better together and avoid surgery, that's pretty much an outstanding goal in my opinion. But acupuncture, yes. I actually trained under a physiatrist who does medical acupuncture. So I learned a lot of her techniques and trigger point injections, and not really stuff I do in practice, but got to see the effects of a lot of it. And it's really impressive stuff if you're going to see a true medical acupuncturist. Chiropractic care as well is something I endorse for a lot of back and foot and ankle pain. And I do send people to numerous massage therapists too. Bunion pain is something I see on a multiple time per week basis, and it's really your pain and symptoms. And I kind of talk to you about what the recovery is like, and if it's your right foot, the limitations on driving and things like that, and what needs to be done. And I would say probably 30 to 40% of patients end up undergoing bunion surgery at some point. And some people, if their toe is really crossing over and it's really painful and dislocated, I'll say, look, it's not a life and death situation, but I wouldn't wait 2 or 3 years. This is going to get really bad, and it's going to be impossible to fix it. So a lot of people, I meet with them, they'll come back a year later and say, I'm thinking about it, let's do it. So I'll usually tell people, a year or two, if I see something that's going on, like a bad crossover toe, or they're starting to get a lot of pain underneath their lesser toes, their smaller toes, because the bunion's so bad. I'll tell them, look, don't wait longer than a year or two. I don't care if you come back to me or you go somewhere else, but you should get this fixed before it really gets bad. And then you're going to say, I wish I did 3-4 years ago. Yeah, so hallux limitus is just arthritis in the joint, and it tends to be progressive. The longer you wait, the worse the arthritis gets, but it's sort of, and I liken this to a knee replacement. So you get injections, you get an arthroscopy to clean up the knee, let's say. We can do sort of similar ideas in the toe. So we'll do injections, we can pad it, do orthotics, much like a brace for the knee, and we can do a cleanup or a replacement as a sort of temporary procedure, but the real definitive is fusing it like the knee replacement. And it really depends on your symptoms and your limitations. There's no rush. And I tell people this all the time, and maybe I should stop and just operate more, but I tell people there's no rush. It's up to you and your symptoms. And if it's bugging you and stopping you from doing things, playing with your kids, your grandkids, walking, exercising, think about the options, and we'll have a honest conversation about how long it's going to take you to get better. So there's a number of different ways that hammer toes develop, and it's oftentimes due to a muscular imbalance where you'll get a contracture literally gripping the ground with your toes. It's called flexor substitution, where you actually flex to hold on. And over time, the joints can get arthritic, the contractures can become permanent. And you can also have extensor contractures where the extensor tendons actually pull the toes up. And it can definitely lead to imbalances. Toes are really important with balancing and gripping the ground, and if they're not functioning properly, it can lead to unsteady gait and a flat-footed gait, or walking back on your heels and lead to falls. Depends on what needs to be done. Sometimes the joint behind it needs to be rebalanced, or the bone behind it needs to be realigned too, but really not terrible. And again, everyone's different, but I've had patients in just days have their stitches out, and in 2 weeks back into a sneaker after a hammer toe procedure. But toes can swell. And I've also had patients that for 4 or 5 months have had, why is my toe swollen? Why is my toe swollen? So it's not perfect, and I'm not perfect, but most of it works out fairly well, or I wouldn't do it. And realistic nature is you have to know that there's a chance that my toe is going to be swollen for months. But there's also a chance that you have a really good outcome. And I think the biggest problem with hammertoes in general is, I think, patient expectations and not having an open enough discussion with their doctor and their surgeon about it, and thinking their toe is going to be this 18-year-old, beautiful, reconstructed plastic surgery toe. And I think about a third of hammertoe patients overall, there's been some studies, are dissatisfied. And I think it's mostly because expectations were set that this is going to be the perfect toe. Because a lot of times we actually take the joint out and fuse it. So you end up with a straight, stiff toe. And if you're not expecting that, then you're not going to be happy, because you're not expecting it to be stiff and not move. So I tell you, and we go through the options, and I usually will counsel you on, this is what your toe is going to be like. I generally don't recommend walking barefoot at all. Grass or beach, that's fine. The beach is a really unforgiving, uneven surface that uses a lot of muscles you don't typically use. So walking on the beach is pretty tiring. But there's no rule that says you can't walk barefoot. If it hurts, it's probably not a good idea. Patients with plantar fasciitis should probably avoid that impact on hard floors, because it'll just flare everything all up again. But you know, there's no rule. It's up to you. It's your foot. If you want to walk barefoot, if it doesn't really hurt.
If it doesn't hurt, it's not hurting you.
I mean, if you're running around on concrete or hardwood floors all day barefoot, it's going to have an impact on your foot, whether it's leading to bruising or thinning of the fat pad over many years' time. But probably no big deal. It's not going to flatten your arch by walking barefoot, but I wouldn't go out of the house and walk around or run and things. Sure. So nail fungus is the question. Nail fungus is something that is going to drive you and me crazy. There are a number of treatments, and not all of them are good. I can probably count on one hand the number of times I've prescribed oral medication to a patient for it, meaning like the Lamisil pills or something like that. Some newer ones that claim they're much better tend to be much more expensive. The reality is it's a very difficult to cure treatment, pathology, and the treatments vary. I tend to start with conservative and topical, and I really only tend to aggressively treat it if it's painful. And sometimes just taking the nail itself off and treating the nail bed or permanently removing the nail is the best treatment if you have a really thick, painful nail. But there's a variety of stuff out there, and not all of it works great. I see a lot of knee pain. Being in an orthopedic group, I see a lot of patients with knee arthritis that have flat feet. And I see a lot of patients with back pain. And the most common thing is either some structural abnormality, hip or back, but weakness of the hip abductors and core muscles. And it causes a little internal rotation of the femur, leading to some collapse of the knee. And if you have a flat foot attached to it, the common concept is the young female athlete that has a flat foot and a weak hip with a good knee trapped in between and gets medial knee pain. And it's really common. I probably see that 12 times a month in my practice. And really try to get those patients into a hip conditioning and core exercise program and arch support. And we just try to rebalance things. So your feet affect everything. They're your foundation. And if you have some weak core muscles or weak hip muscles, these things can affect everything. And again, a simple arch support, whether it's over the counter and you get a good brand or custom made, can help balance that with some exercises. And a lot of this can be fixed without surgery. And it really is individual and patient specific. But great question. Cut your nail straight across. Don't dig in those corners even though you want to. Yeah, so if it's bent and curved like this and continues to ingrow, there's a lot of procedures we can do to eradicate that. And having done 3 on myself, I know exactly what it's like. I've done the procedure to myself. And we can remove the edge of the nail and kill the nail at the root. So it actually will narrow the nail a little bit, but it will only grow flat and fill back in with normal skin. It's a really high success rate, and it's done in the office. Simple procedure. So ganglion cyst is an outpouching of fluid. It can come off a joint or a tendon sheath. Tendons have these sheaths that they glide in, and sometimes it can bubble out due to friction. So we see them in the front of the ankle very commonly on the outside where the tendons run. And they can be really painful, kind of swell up and go away and back and forth, and patients almost get tricked into thinking, oh, it's going away, oh, it's back. And then by the time you say, all right, I'm going to go see someone, it calms down. And sort of the old adage is what they used to do with the Bible. They used to smack it to pop the ganglion cyst on your wrist, and it'll go away for a little while. Injections can help, taking the fluid out, and just excising them sometimes surgically is the cure to make them go away. All right, guys. Thanks for coming.
Thank you, Doc.